Hi everyone, welcome to Med Goto. This is going to be a continuation of our last discussion on hypoxemia. So today I'm going to be I'm going to be talking about the causes of hypoxemia. Causes of hypoxemia. And before we talk about the causes of hypoxemia, there are three main determinants that I want us to remember, which is going to make it very easy for us to remember the causes of hypoxemia. Two of them, they are formulas, and the last one is going to be the blood flow, right? So looking at our picture here, so it's just a picture of the airway connected to the alveolar. And of course, we're going to have our blood flow, right? So if this is our alveolar, right? So I'm going to represent it by capital A, right? And it's going to be our blood flow, right? Blood coming in. And of course, as blood is coming in, we expect carbon dioxide to be leaving and an oxygen coming in, right? Gas exchange. So what determines the oxygen in the alveolar, right? From our previous discussion, he said that what determines the oxygen in the alveolar will be what's the indirect, the way we normally estimate it indirectly, which is our alveolar gas equation, right? And who remember the formula for the alveolar gas equation? Anybody remember? Okay, so the formula for the alveolar gas equation, right? So three things I want us to remember. Number one will be the formula for the alveolar gas equation, which is P capital A, right? Partial pressure of oxygen, right? P capital AO2, right? Which is partial pressure of oxygen in the alveolar equals to our barometric pressure, right? Minus the water vapor pressure, right? Multiplied by our FiO2, right? Minus the partial pressure of carbon dioxide divided by respiratory quotient. And if you have not watched the video on the alveolar gas equation, I strongly encourage you to watch that video. That will give you a lot of insight into this formula. The second thing that we also need to remember so that we can appreciate the causes of hypoxemia is diffusion, right? Because once we get the oxygen into the alveolar, the oxygen needs to diffuse into the capillary, into the blood, right? And then be able to dissolve in the blood, right? So the second one is going to be the formula for diffusion, right? And the formula for diffusion, right, is going to be our area, right, multiplied by diffusion coefficients, right, dk, diffusion coefficients, right, multiplied by the differences in partial pressure, right, divided by our alveolar wall thickness, right? So the A will be the area, the delta L will be our alveolar wall thickness. And then for the purpose of this video, we're only interested in the area and the alveolar wall thickness, right? And the third thing I want us to remember is going to be the blood flow, right? And if you can remember these three things, it's going to be very easy for you to remember or to know the causes of hypoxemia. So the way I imagine it is the determinants of the oxygen in the alveolar, which is the alveolar gas equation, the determinants of the oxygen in the for the oxygen to get into the plasma, right, to diffuse through. So that will be help of diffusion, right? Which is, and diffusion is directly proportional to the area, the surface area, and inversely proportional to the alveolar wall thickness, right? And the last one is the blood flow, because we need the blood to flow. So having said that, so I want to just quickly review how blood flows, right? Because from the heart into the lungs, right? Just a quick recap for us. So the blood that is coming from the superior vena cava, inferior vena cava, that goes into the right atrium, right? From the right atrium to right ventricle. And in those blood, they are deoxygenated blood, right? Meaning that they have low oxygen in them, right? So from there, they go through the pulmonary artery, right? Because artery carries blood away from the cardiac system, right? Into the lungs. And at the level of the pulmonary capillary, we know that gaseous exchange is going to take place. So oxygen goes into the alveolar, and carbon dioxide leaves, right, from the blood into the alveolar, and oxygen will come in exchange for it. And the oxygenated blood now, so after the blood is being oxygenated, they want to leave the lungs through the pulmonary vein into the left atrium, from there to the left ventricle, and then we can pump them out into the rest of the body. So having said that, so now let's move on to talk about the causes of hypoxemia, right? So just don't forget our the formulas that we mentioned, right? So hypoxemia, right? From our last discussion, we said hypoxemia is decrease in the concentration of oxygen that dissolve in plasma, right? Or in other words, decrease in the partial pressure of oxygen, right, in the arterial system. So decrease PaO2. And whenever we see hypoxemia, what is the next thing we need to ask ourselves? Anybody wants to guess? Very good, right? So we need to know what the AA gradient is, right? So if you said AA gradient, that's really good, right? So we want to know what the AA gradient is. And we spoke about AA gradients in the previous lecture. So if you have not watched the lecture on AA gradients, I strongly encourage you to watch our discussion on AA gradient, right? So we want to know what the AA gradient is, right? And like we said that AA gradient is the difference between the oxygen, partial pressure of oxygen in the alveolar, and the partial pressure of oxygen in the arterial system or in the capillary. So that will be the difference that we look for. We're looking for the difference in AA gradient, right? And then we said that the AA gradient could either be normal, right, or it could be increased. So we can have increased AA gradient. So, so let's go through the causes of hypoxemia with normal AA gradient. So the way I normally imagine the causes of hypoxemia with normal AA gradient, I think of anything that decrease this oxygen, the partial pressure of oxygen in the alveolar. So anything that decreases the partial pressure of oxygen in the alveolar will cause hypoxemia with normal AA gradient. Because like we said in the previous lecture, right, if the partial pressure of oxygen in the alveolar is decreased for no reason, that will also decrease the partial pressure of oxygen in the capillary system, right, or in the artery. So as a result of that, because both of them are equally decreased, the gradient will be preserved, right? So the AA gradient will be normal, right? And so what are the causes of hypoxemia with normal AA gradient? So looking at our formula for alveolar gas equation, right? So number one will be if there's increase in carbon dioxide, right? If patient is retaining a lot of carbon dioxide, because if the carbon dioxide is increased, right, that will further decrease our this equation, because that means there's a lot of, for instance, let's say carbon dioxide is increased, so that means we need to take out a lot of carbon dioxide from this equation, and that will decrease the oxygen in the alveolar. And that makes sense, because if there's a lot of carbon dioxide, the partial pressure of oxygen in the alveolar will decrease, because there's less space for oxygen to come into, right? So that would be number one. So number one is going to be increase in carbon dioxide, right? So patient is retaining a lot of carbon dioxide, right? We should normally call hypoventilation, because in the previous lecture, we said that ventilation is a word for carbon dioxide, right? So if a patient is hyperventilating, that means they're blowing out a lot of CO2. So the CO2 in the blood is going to be low. But if they are hypoventilating, so that means they're retaining a lot of CO2. So the CO2 in their body is going to be high. So number one is hypoventilation. And the second one is decrease in partial pressure of inspired oxygen. And if you guys remember, this equation right here, right, is our partial pressure of inspired oxygen, right? And like I said, make sure you watch the previous video, you understand what I mean by this, right? So if anything decrease our partial pressure of oxygen in the inspired air, that will also decrease the oxygen in the alveolar, and that will cause hypoxemia. So that will decrease the oxygen in the capillary. So that will cause hypoxemia with normal AA gradients, right? So that's how I imagine them. So two major causes of hypoxemia with normal AA gradients: hypoventilation because of increase in carbon dioxide, right, and a decrease in PiO2. So let's look at them. So going back to our diagram here, right? So number one is going to be our hypoventilation, and which basically means increase in PaCO2. And the causes of this hypoventilation will be made probably there is a decrease in respiratory drive. And of course, we're going to make a separate video to talk about causes of hypercapnic respiratory failure, right? Or increase in CO2. So decreased respiratory drive, which can be as a result of maybe sedation, patient that is taking medication that is making them suppressing their respiratory drive, or it could also be CNS injury. Right? So like patients who have things like encephalitis, which is inflammation of the brain, right? Or meningitis. It could also be due to neuromuscular diseases, right? So neuromuscular disease that is affecting the muscle, right? So something that is affecting maybe the transmission of information from the neurons into the muscle. So in other words, the muscle is not getting the signal, it's not well innervated, right? Or the muscle itself, there's something wrong with it, it's weak, right? Because if the muscle is weak, like particularly the diaphragm, because the diaphragm is a major muscle of inspiration. So if patient is not breathing in enough oxygen, so oxygen cannot extend for the carbon dioxide. So as a result of that, those patients will be retaining a lot of carbon dioxide, right? So neuromuscular disease, right? So like problem with the diaphragm, right? Anything that affect the diaphragm, right? Guillain-Barré syndrome, GBS, we call it Guillain-Barré syndrome, which is a problem with peripheral nerves, right? So denervation. So the diaphragm, so the phrenic nerve that supply the diaphragm will not be working very well. The other one is ALS, right? Amyotrophic lateral sclerosis, which is also a problem with both upper motor neuron and a lower motor neuron. So that also prevents the diaphragm from being innervated very well. So the diaphragm is going to be affected. And then the most common cause of death in this condition is actually respiratory failure, because the diaphragm is not working, and those patients start retaining a lot of CO2, their oxygen goes down, they develop hypoxia, and they die from it. The other one is myasthenia gravis, right? Whereby this patient, they are making a lot of antibody against the postsynaptic acetylcholine receptor, and as a result of that, you cannot transmit information into the phrenic nerve to be able to innervate the diaphragm, right? So they also have weakness. And of course, things like fatigue, right? So if people are very weak, maybe from the conditioning, all the stuff, that will also cause hypoventilation. The other thing that will also lead to hypoventilation is obstruction during exhalation, right? So when patients are supposed to be breathing out, right? So if there's obstruction, because remember during exhalation, right, we blow out the CO2, right? So if there's obstruction to that outflow of that CO2 during exhalation, that will also cause retention of CO2. So things like COPD, right? Sleep apnea, right? So there's something that we call obesity hypoventilation syndrome, which is a form of sleep apnea, whereby those patients are retaining a lot of carbon dioxide. So these are the three major causes of hypoventilation. So I look at them. Is there something wrong with the respiratory drive? Is there something wrong with the muscle itself, right? Or is there an obstruction to the during exhalation, right? And the second one that we mentioned is decrease in the PiO2. And remember, the formula for PiO2 is our P atmosphere, right? Or barometric pressure minus water vapor pressure, right? Multiplied by FiO2. So if there is a decrease in these, right, in the atmospheric pressure, example in the case of high altitude, right, so that could lead to decrease in PiO2. And of course, the other one, if there's a decrease in FiO2, FiO2 could be decreased in a situation like, for instance, if somebody is on oxygen already and their oxygen tank is empty, right? So empty oxygen tank. So if the tank is empty, right? Or if the tube that connects the oxygen to the patient become kinked, right? For no reason. So that could also decrease our partial pressure of inspired oxygen, right? So these are the causes of hypoxemia with normal AA gradients, right? So now let's move on to talk about the causes of hypoxemia with increased AA gradients. And the way I imagine the causes of hypoxemia with increased AA gradients, I always think of condition whereby we are able to get the oxygen we're able to get the oxygen to the lungs. Maybe perhaps there's a problem with the oxygen diffusing through, right? Or we are not bringing in enough oxygen to be able to enough blood to be able to exchange for those oxygen, right? So let's look at them and let's figure out how we can see how we can figure them out, right? So in hypoxemia with increased A gradient, I think of we can get oxygen in, but the problem is that the oxygen cannot diffuse through, or there's no blood being exchanged for it, right? And there comes in this formula, the diffusion formula, right? And the blood flow, right? So to remember the causes of hypoxemia with increased AA gradients, so the first thing we want to ask ourselves is to be able to remember them very well. Is first thing, if I give this patient 100% oxygen, right? So I give this patient 100% oxygen, or you increase the FiO2 to 100%, does it correct the hypoxemia? Right? So that's the first question you want to ask. Does the hypoxemia improve with 100% FiO2? So remember, normally at a sea level, right? Our FiO2 is normally 21%, right? And for each liter, 1 liter of oxygen that we get on, right? For each liter, like I mentioned from the previous video, that will increase our FiO2 by about 3%, right? So if you bump up the FiO2 to 100%, does it correct the hypoxemia, right? And if the answer is no, then we're dealing with what they call true shunt, right? So we are dealing with shunt. And then what does that mean? What does shunt mean? Normally, the way our body is designed, or the way our respiratory system is designed, the ventilation must match with perfusion, right? Ventilation, I always think of ventilation as the gas, right? The oxygen that is coming in, right? And I think of perfusion with the blood that is flowing in, right? So like we mentioned, if we look at our diagram, right? So ventilation, gas comes in, blood is also coming in. So both of them, right? They need to match with each other. So in a such a way that our VQ should be equal to 1, right? So when you look at the VQ, it should be equal to 1, right? So ventilation should match perfusion, right? So when the ventilation, either the ventilation or the perfusion equals 0, that will lead to what we call shunt. Because that means there is no, so for instance, let's say the ventilation is 0, that means even though blood is coming in, we can't get oxygen through, right? There is no diffusion taking place. So the same way the oxygen is coming in is the same way the oxygen is leaving, right? Like the same thing, if the perfusion is 0, right? If you are not getting any blood, like somebody who have like a major P, right? Like what they call saddle embolus, that's obstructing that's obstructing the major pulmonary trunk, right? So in that case, no blood is coming in, right? Blood is not coming in, and then if the pulmonary trunk, of course, this patient to die, we don't want to see, because this is going to lead to, if the blood flow is 0, that patient is not going to make it, right? Because at the end of the day, no blood is coming in, or even though we have ventilation, definitely the VQ will also be what the perfusion is 0. Another one is if the blood is passing through somewhere else, instead of the blood to be passing through the lungs, right? Passing through the capillary for exchange, if the blood is passing through somewhere else, like for instance, let's say there is a big hole in the cardiac system, right? There's a connection in between the chamber, so the blood is passing through the defects in the cardiac system, right? From maybe between the the right atrium and the left atrium, and it's not going to the lung. So that could also create a shunt. And the shunt could also happen inside the lung itself. So let's look at the causes of things that can cause shunt, right? So the shunt, so to remember the cause of the shunt, it could be a shunt in the cardiac system itself, right? Like what we call right to left shunt, right? So like right to left shunt. And if you look at our diagram right here, right? So for instance, like I explained earlier, right, as the blood is flowing in from the SVC, IVC, ideally the blood is supposed to go from the right atrium to the right ventricle, and from there goes into the pulmonary system and then going to the lung for oxygenation, right? But if there's a big hole, right, in between the right atrium, left atrium, or in between the right ventricle, left ventricle, instead of the blood going to the pulmonary system, the blood can actually pass through there, right? And then go from the right atrium to the left atrium, or from the right ventricle to the left ventricle without going to the lungs. So that would be a shunt. Because at the end of the day, all the blood that are ending up in the circulation, in the systemic circulation, they are purely deoxygenated blood. So that would be a true shunt, right? Another cause of true shunt would be if it's happening in the pulmonary, right? In the lung itself, right? So number one could be a problem with the vessel, like what we call pulmonary AV malformation, right? So pulmonary AV malformation, AV stands for arteriovenous malformation or arteriovenous malformation. So this is a connection between the artery and the vein, or the arterioles and the venous, boycotting the capillary, because the gaseous exchange occurs at the level of the capillary. So if they are boycotting the capillary, that will lead to a true shunt, because at the end of the day, those blood are not being exposed to those oxygen that are coming in through the alveolar. So a case like in this case, so if this is our pulmonary artery and this is our pulmonary vein, so instead of the blood going into the capillary for gaseous exchange, so the blood is just passing directly, right, from the pulmonary artery into the vein, boycotting the circulation. So that would be another example of true shunt, right? So pulmonary AV malformation, right? And which is very common in patients who have example like condition like hereditary hemorrhagic telangiectasia, right? H2, hereditary hemorrhagic telangiectasia. So that could be seen in those individuals. The second one could be if the alveolar itself is collapsed, right? So if there's a collapse of the alveolar. So if the alveolar is collapsed, like in the case of atelectasis, So when we use the word athleticism, basically means alveolar collapse. So if there's alveolar collapse, in that case, the ventilation here will be 0, right? Because there's nowhere the air can come into, right? So that's also another cause. Another one, the third one, will be if the alveolar, so in this case, alveolar is not collapsed, but the alveolar is filled with something, right? Is filled up with something. So there's something filling the alveolar. It could maybe the alveolar is filled up with fluid. Maybe there's fluid in the alveolar, or there's cells or debris in the alveolar. Example of this case could be ARDS, right, which is acute respiratory distress syndrome, and whereby the alveolar are filled up with a lot of inflammatory cells, right? Another one could also be a very bad pneumonia, whereby they also fill up with inflammatory cells, bacteria, right? It could be pulmonary edema, right? Very bad pulmonary edema, whereby the alveoli are filled up with a lot of transudative fluid. And the last one could be alveolar hemorrhage, right? Whereby patient is hemorrhaging into the alveolar, they are bleeding to the alveolar, and that will also fill up the alveolar, and that can make the V become 0, right? So don't forget, so just to make sure we are still following, right? So hypoxemia, what is the A gradient? So A gradient is increased. I give this patient 100% oxygen. Normally, ventilation is supposed to match perfusion. So if you give somebody 100% oxygen, so far the ventilation is not 0, perfusion is not 0. The hypoxemia is supposed to improve. But if the ventilation is 0 or perfusion is 0, and the hypoxemia is not corrected by the 100% oxygen, then we are dealing with a true shunt, right? And like we mentioned, it could be a cardiac cause or pulmonary cause. Another cardiac cause, right to left shunts. Under pulmonary shunts, under pulmonary cause, it could be pulmonary AV malformation, as seen in patients with hereditary hemorrhagic telangiectasia, or it could be alveolar collapse, whereby the alveolar has collapsed. In that case, the ventilation there will be 0, right? Like in the case of athleticism, or the alveolar is filled up with a lot of maybe fluid or cells, like in the case of ARDS, pneumonia, pulmonary edema, or alveolar hemorrhage, right? So let's say we give this patient 100% oxygen, and then the hypoxemia improve, right? So if the answer is yes, right? So hypoxemia improve in that case, right? So what are we dealing with? So that means we still have some ventilation going on, right? We still have some perfusion going on, right? So the ventilation is not 0, or the perfusion is not 0. So it could be either there's impairment, right? Impaired diffusion, right? So there could be impairment in diffusion. So problem with diffusion, right? And if you go to our formula with diffusion, remember I mentioned earlier, right? 2 things that we need to remember about our formula with diffusion, right? Is to remember diffusion is directly proportional to the surface area and inversely proportional to the alveolar wall thickness. So if the alveolar wall thickness is increased, if the wall is really thick, that would create a problem for the oxygen to diffuse through. The oxygen will not be able to diffuse through, right? An example in the case of fibrosis, right? And if the surface area is decreased, that will also decrease the amount of surface that we need, that we have for gaseous exchange to take place. And that will also decrease diffusion, right? Example in the case of emphysema, right? So under diffusion impairment, we could have fibrosis, right? Fibrosis could fall under that category. And the other one is also emphysema. And the reason why I put emphysema here, right? Because emphysema could also fall under VQ mismatch, which we can also talk about in a second, because that will especially there's obstruction to airflow, right? And emphysema will also fall under hypoventilation. So you have to understand the patient that's in front of you, right? So emphysema could fall under impaired diffusion, could be under hypoventilation, right? And it could also be under VQ mismatch, right? So diffusion, impaired diffusion. The other cause of hypoxemia with increased air gradient that improve with 100% FiO2. Another example is going to be what we call VQ mismatch. So in this case, there's a mismatch between ventilation and the perfusion. So it's not zero, like what we saw in shunt. It's not that the V is zero or the Q is zero. Here, it's just a mismatch. There's a little bit of mismatch. Maybe the ventilation is a little bit decreased or perfusion is a little bit decreased, but it's not like 100%. Right? It's not like they are zero. So example is I divided them into vascular, alveolar cause, or airway disease, right? So let's start with the vascular, right? Under VQ mismatch. So we expect the vascular is going to be affecting the what? The perfusion. So the perfusion is decreased. It's not zero. So a classic example is somebody who has a P, pulmonary embolism, right? So with pulmonary embolism, right? With the release of inflammatory, because of the release of the inflammatory mediators, sometimes those patients can develop some athleticis in that area where the pulmonary embolism is affecting. And as a result of that, that will affect, that could cause a VQ mismatch in that area of the lung. And remember, it's not the whole entire lung that's affected, because if somebody has a major PE that is blocking the main pulmonary artery, that could make the ventilation to be, the perfusion to be zero, and then that becomes protrusions, right? And that can kill them. So that's P, pulmonary embolism. The other cause is alveolar, so something that is affecting the alveolar, right? Example like in the case of pneumonia or in the case of CHL. So this is a patient that is having, so like in the case of pneumonia, so same thing, similar to what we see under protrusion. So in the case, maybe this is just a pneumonia, whereby the alveolar is also filled up with a couple of things, right? Thereby affecting the ventilation, but it's not affecting the ventilation here is not zero. So the ventilation is mildly decreased, right? Because of those inflammatory cells that are filling the alveolar, right? So in this case, there's still some ventilation, but it just decreased. The next example is also CHL. Same thing, maybe not really a bad CHL, maybe just some exacerbation on CHL, whereby the alveolar are also filled up with fluid, but they are not filled up to the extent that the ventilation now is now zero. Right? So just mild decrease in ventilation. The next one is the airway disease like asthma, COPD, right? And of course, we can also add another thing that we can also add here is also mucus plug. And with asthma and COPD, right? They are not bringing enough because of the obstruction to exhalation, right? So it's an obstruction to exhalation. So during when they are exhaling, right, it's an obstruction during that time. So they are having trouble getting rid of, they're having trouble with ventilation. So the ventilation here is not zero, right? It's just also mildly decreased. So as a result of that, that will also fall under VQ mismatch. And of course, mucus plug. So somebody have like a thick mucus that's blocking the one of the airway. That will also affect ventilation in that part of the lungs. But of course, that would decrease the ventilation, and that will also cause a VQ mismatch. But bear in mind, if the mucus plug is so big and is obstructing maybe the right mainstem bronchus or left mainstem bronchus, that could cause a whole lung to collapse. And if that a whole lung collapse, then that fall under protrusions, because that will become what? That will lead to athleticis, and that will lead to protrusions. So just to make sure we kind of like apply to what type of patient we're dealing with. And I hope this helps us to be able to understand the causes of hypoxemia. And let's not forget, whenever we see hypoxemia, first thing is always ask, what is the A gradient? And that will help us to come up with our differential. And I hope this helps us. And don't forget to subscribe to this channel. We're going to be uploading more videos on respiratory physiology And we're also going to be starting a USMLE series very soon to help the students who are studying for the USMLE exam. Thank you for watching.